All right, first there was epi, and then came health behavior. So the branch of science that deals with determining the incidence, distribution, and figuring out the control of diseases by looking at risk and protective factors is, in a nutshell, what epidemiology does, and biostats is alongside that. It's very quantitative, although outbreak investigations, etc., look at getting into the field and collecting much more contextual data. Even though it started in very clinical settings to look at disease, more or less just reactive. The disease is there, what's going on, we have to understand things as they emerge in healthcare settings. And now we have much more sophisticated epi, an entire branch of social epidemiology where the focus is actually looking at social determinants of health and looking at social mobility and movements of groups and versus just necessarily individuals. So we cannot do health promotion, health behavior without epidemiology and biostats. Together, we're much stronger than we are apart. So behavioral science has come along, and everything we do, we start with assessment and quantification. When we identify a problem, it's essential that we explain the burden and communicate which groups are more vulnerable, what disparities exist, what risk factors are known, so that we can take this information and use that. Our science uses epi data and biostatistical data to understand the root causes of the lifestyle factors associated with modifiable disease and conditions of disease and disability. And we utilize and develop theory to explain and predict how we can potentially modify human behavior so that ultimately disease can be avoided. And there's a classic parable, if you will, in public health. And a student, in her introduction, she noticed that I had a master's of social work, and she said that she'd like to talk to me about how that degree complements my public health training. And I think the parable shows it clearly. So there is a person at the side of the river, and they hear somebody screaming for help. So they go and they run and they get a lifesaver and they throw it out, and they're able to put it around the person. They drag them to the side, and they have to pull them out. Their body is so heavy from being in the water with their clothes on, everything. They have to resuscitate them. It's draining, and not before long then they hear another voice, another set of screams. Oh my gosh, another person fell in and they need to be saved. Over and over and over. That is what we call the downstream response in healthcare and in social work. It is truly at tertiary level of prevention. We are dealing with people who have already fallen into the river. They have the condition. It is no longer modifiable. And it is costly, and it is tiring, it is exhausting. So in public health, our entire goal is to work upstream. What on earth is making the people fall in the beginning? Is it just because we should just start to teach them how to swim and then they won't need to be saved anymore? Or is there something else fundamental? Are they building their houses too closely? Are they living there and there's a fence needs to be built? What can we do to prevent people from drowning. And that analogy hopefully will stick with you. You're going to hear it and see it a lot, that our entire goal. But I think the more you realize how everything in the US in terms of healthcare it's almost intentionally built that we will train more doctors and get more people in healthcare to fix problems versus getting more people trained to prevent people from ever getting sick in the first place. If we truly had the resources, but a lot of people do not support telling people how to live their life and what to avoid. There are a lot of people that do not want to invest in preventive services. So some of your healthcare plans will not cover preventive care, but they will prevent or give you coverage on treatments, if you've ever noticed that. So hopefully with that you start to see more and more that, but there are really great things that if you cannot afford, like some of the vaccines, if you had to pay out of pocket, I'm not going to pay, $200 for a flu shot when if you get the flu and you get very, very sick and you have to go into the hospital, I guarantee even the call to get you to the hospital would be far more than $200. If you can't afford the preventive measures, you will never be able to afford the disease, and that is the reality. So I wanted to say to the student that asked me about my Master of Social Work that without my dual understanding of how difficult life is for the people who have fallen in, it has only made me much more sensitive and reactive to build those fences a lot faster. Okay, so health promotion and behavior has a defined set of tools. One is theory and another is a model. Theory can be defined as a set of interrelated concepts, constructs, and propositions that present a very comprehensive, systematic view of a domain of study for the purpose of explaining and predicting the phenomenon. We can't just ask for money to develop a pilot program, for example, if we're not going to be very logical and convincing that what we're setting out to do has a clear basis for doing so, that there's a rationale, that we can cite other promising practices. And another tool that we use a lot is a model. It's a framework to help us organize whatever our targeted behavior is, to show relationships between the parts and the outcome of interest. So the pathway models that you viewed in the initial presentation, that's another example of a model. So as we looked at in session 1, the social ecology model has multiple levels of influence that can't be overlooked. We can't just merely focus on the micro individual level, that the interpersonal between people, the social, think about teens and their relationship with their friends, parents, families, then the next ring of influence, the community, the places you work, rules in your neighborhood, for example. These all have an impact on what you're able to do and how you can live. And so it's essential to be versed in a variety of theories. There are so many, and on each of those ecological levels, there are a number of theories to consider. So you want to look at both your pathway to kind of map out generally and then find a theory that can fit. And so one concept that we use in health promotion is Well, it's most commonly used is that people just don't know. They behave in one way because they don't know better. And so a lot of our interventions will take into account that knowledge and attitudes can be influenced by a curriculum, for example, or messaging in a social marketing campaign or a public service ad. So the bulk of social science research or health promotion and behavioral research is concentrated on cognitive factors, that micro level on the individual that relates to their health and illness. And we do that because it's accessible, it's simple, and these are the least costly variables to try to influence. So this is the prevailing paradigm supported, that if we could change the minds of the targeted audience or population, we can improve their health. But we know that this is very short-sighted, that you can't just change somebody by giving them education in one brochure and they're going to be able to stop smoking or eating, poor nutritious food choices, for example. That it has to be a combination of things, that maybe we can tell them why eating poorly is bad, but maybe we can put a tax on it and hurt them economically and influence something. Maybe that will be an influence. Not hurt them physically, but make them feel like that cost that is going to actually have a bigger impact than just in. All right. Another concept in health behavior is giving a lot of attention to developing measures for specific health behavior. So one common theory is the stages of change model, that people are in. You can't just create yes/no questions. Do you work out? Do you yes/no? Because if I did ask you that, everybody would feel socially pressured to say yes, or maybe some of you would admit that you don't. But that if you could that there's a curve of readiness or willingness to do something. So if I said, how many of you have worked out 5 days consistently in the past week and hit your target heart rate? Probably some of the hands that, if I just said, do you exercise? All of them would be up, some of them would go down. But if I said, how many of you are actually thinking about working out and maybe have new running shoes and a Fitbit all charged up and you're ready to go? If that describes you, you're in a different stage according to the stages of change model. And I would be able to do tailored strategies to help you move along, versus someone who doesn't even want to work out. They don't like sweating. They don't like it at all. It's work. So if you don't have any desire to do it and you know it's the right thing, you're going to be the hardest to change. It's not impossible, but where would you, in a limited public health budget, want to put your money? I would want to put it towards somebody who's in a preparation stage. They're ready to go. They just need a little bit of motivation or something, some other carrot to get them to move. So these are ideas that we have to try to capture and measure very creatively so that we can test our theories. It's really, really difficult to work with health promotion and health behavior and testing interventions. Human behavior is so complex. That's what makes it difficult, but the challenge can invite the most creative minds. And I know from reading all about you guys, from seeing your pictures, from hearing where you've been and what your training is and your interests, I know that you guys are going to be a stellar cohort and have a lot of ideas of how to tackle these major public health issues that we face. So another concept is culture. How do we try to approach changing the culture of something. We don't just look at people by the boxes that they checked for how that describes them. We're part of something much bigger. And this is really, really important as we shape our programs and our interventions and outreach efforts. That the social environment is really, it is quite, it invites a lot of investigative energy and innovation and understanding what are the sources of stress and how do people use their social networks and support to get through times like what you saw in the video and what you will see in future segments too is how positive and how amazingly protective social support and networks can be. So that's something else that we also look at. So really quickly, theories as they correspond briefly on the ecological levels. The intrapersonal are the individual level models. It's the person's knowledge, attitudes, perceptions about a health issue that affects his or her health behavior. So our common, really popular theories on the individual level: health belief model, theory of planned behavior, the trans-theoretical or stages of change model that I spoke of earlier. Self-regulatory models are on the individual level. On the interpersonal level, it's how people are affected by social influences, your family, your work setting, your friendships, your organization. So one really commonly used theory, social cognitive theory. Another one is this diffusion of innovation. But social cognitive, modeling, outcome expectations, self-efficacy, behavioral capability. I think The Biggest Loser is a great example of many constructs at work. You've got people who are incentivized to work out like crazy. They're modeling the behavior, self-regulation, and the fact that you're going to be going on a scale in front of millions of people. That is going to have an impact than if I was a nutritionist meeting with you individually and you had to self-report your weight. As you can see, there's intentional things that are done and they can be theoretically described. On the widest rungs of the ecological model, the organizational and macro level model, levels of influence in the ecological model, we have community level change, we have MATCH as the mobilizing action through community health, we have the MAP-IT approach, we have community mobilization, we have cultural models, societal level models, policy advocacy models. There are so many, so please read our required readings and this will make much more sense. I'm just doing a quick introduction for you. So I'd like you to move on now and continue with your readings, and then please review the project guidance. Hopefully you're going to understand at the end of the session why behavior matters. It is so important, if not the most important influence on chronic disease and preventable health conditions. I want you to understand more about how we use theories to explain what we're doing, because these are essential to help you have success in this class. And so now is the time to unveil what you're going to be working on for the next 5 weeks in terms of developing a special project and my rubric for which I'll grade your projects. When you start to see what other students have done, I hope you start to get excited and see that it can be a lot of fun to be in health promotion and behavior, to dream of what could be possible to help groups that are marginalized and truly social injustices are affecting their health. and then it won't be long and I'll be reviewing your project proposals and we'll move forward. Okay, thank you and have a great weekend.